glad you guys are here. Well, we're just going to start because I have about 50 slides, and this is also recorded as well too. So thank you for being here for our talk on what every employer should know about COVID testing and return to work. All right, so let me tell you my story. This is me in early August. I actually was diagnosed with COVID on August the 5th of this year. And so this is a topic I'm very passionate about. I was in the hospital. I had fever, I had fatigue and whole body aches, and was symptomatic. It went on for about 5 days, and then within 24 hours, I got severely shortness of breath, and I was hospitalized and was moved to ICU. And you see this contraption on my nose right here. This is me in ICU on not a ventilator, but almost like a ventilator. It gives me 60% oxygen. So room air is 21%. And the oxygen is flowing into my nose at 30 liters a minute. So that is very fast. So but even with that, I was moderately short of breath, but I was not dying. I was in CU for about 4 days. No, about 4 days, but I went home on August the 13th, and I came very close to being on the ventilator, which is the breathing machine, this is almost the next step. So if I was gonna still be short of breath and my oxygen saturation was below 90, that would be the next step. So when I was in the ICU, my chances of death was actually 40%. I also had ARDS, which is acute respiratory distress syndrome, and I also have COVID pneumonia in both of my lungs, in the upper lobes and also in the middle lobes as well. And I'm 54. I have no medical problems, and I exercise and I eat well and I take supplements. So it happened to me, it can certainly happen to anyone else. And I'm definitely not in the group where you hear about are the most susceptible. So that is my story. The objective of the course today is to discuss about how COVID infection spread and talk about the viral load. So if I may be going to a little bit too much, but I really want you to understand what is going on, because it's a little confusing for even for healthcare professionals to understand, and there's a lot of variables. And the second part is the role of testing. Why do we test, and what is testing, and infection risk assessment and mitigation of the spread. So these are the sources that I go to. The Virginia Department of Health, the CDC, NIH, Harvard, Stanford, and University of California, San Francisco, the Infectious Disease Society, clinicaltrial.gov, and peer-reviewed evidence-based medical literature. So let's start with just some basic stuff. What are the definitions? Because the definition sometimes itself is a little confusing. So the virus is called SARS-CoV-2, which means for severe respiratory, a severe acute respiratory syndrome coronavirus. And the SARS-CoV-2 coronavirus is the coronavirus causing the outbreak. The reason why they name it coronavirus because the virus has all these spikes, the protein spikes, and this is a one-cell virus here, and it looks like a corona. That's why they call it corona. So the clinical syndrome, the disease of the coronavirus, SARS-CoV-2, is called COVID-19. So this is the clinical syndrome, and this is the name of the virus itself. So briefly, corona virus or COVID-19 disease has shortness of breath, fever over 100 degrees, a dry cough. It's a gradual onset, headache, aches and pain, sneezing, fatigue, and diarrhea, and also a loss of sense of smell and taste. Clinical presentation really quickly. I want to stress the part about disease categorization. I mentioned about the symptom, the most common symptoms after we've known this disease now for about 6 months is fever, cough, and shortness of breath. These are the most common symptoms here. And of 100% of people, about 70 to 80% is non-severe, and these could be asymptomatic or very, very mild symptoms of just a sore throat, a runny nose, or headache, or even a little bit of nausea and vomiting. However, between 30 to 20%, you get severe, and then about 5% of that, those are the ICU. So I'm in one of these 5% right here, where I was at in ICU. So clinical features, I mentioned ARDS, which means for acute respiratory distress syndrome, which COVID-19 can cause. And it caused a pneumonia, which means an infection in the lungs. And what SARS-CoV-2 does is that it fills up your lungs. So that way your alveoli, which are the tissue in the lungs that help you oxygenate, it cannot exchange oxygen. And it usually happens about the second week of your symptom. And when you do have ARDS, about 20-30% require ICU care. And ARDS happens between 17-29% of hospitalized patients, and the mortality rate is quite high, even up to 15%. And the older you are, the higher the mortality rate. So let's go briefly.
I think you have some people that need to be let in to the room.
I don't know. Tori, are you able to let them in?
Everybody's in.
Everybody's in.
Supervisor's texting me saying she's trying to be let in.
All right. So let me continue, and then Tori can help out with that. All right. So this let's talk about a little bit about SARS-CoV-2 and how does it get into your body and what does it do. So it's a one-cell virus here with the spike protein, and these little squiggly lines are the RNA, which is the genes of the virus, and it goes into the tissue through the receptor called the angiotensin converting enzyme 2, and most of our tissues in the body have this. So it enters the body through here, especially in the lungs have this, and the cell in your body takes it in, and then it releases is RNA, which stands for nucleic acid, ribonucleoside nucleic acid, and then it replicates it. Your cells start to replicate more of this RNA, and then from there it uses your protein, your cell's protein making machinery to make another virus, a new SARS-CoV-2, and then it goes to another cell and infect another cell. And this happened exponentially over time. So it goes into your cell and it uses your cell to replicate itself, so that way it can make more of itself to infect more tissue. So the transmission, what the CDC is saying, that is mainly between people in close contact with one another within 6 feet, and it's mainly in enclosed indoor space. And you hear me say this a lot. And it's mainly person-to-person spread, and droplets is the primary, but we all know that there is a chance of aerosol spread as well. And it's mainly through the respiratory droplets produced by an infected person who cough or sneezes. The droplets can land in the mouth or nose of people who are nearby, or possibly be inhaled into the lungs. And people are thought to be most contagious when they are most symptomatic, or even before they are symptomatic, and I'll show you why. Some spread may be possible before people show symptoms. That means they're asymptomatic. And shedding of the SARS-CoV-2 is 1,000 more times than the flu. So infections occur through droplets in close contact. So an analysis of 75,000 COVID cases in China, the clusters occurs in mainly in household setting, and the transmission occurs in close and prolonged contact. And outside of the household setting, those who had close physical contact, share a meal, or were in enclosed spaces for approximately 1 hour or more with symptomatic cases or in the infected individual, such as in places of worships, gyms, or the workplace, were also at increased risk of infection. Environments that are enclosed with poor air circulation and high density of people, it spells trouble. So what's the transmission mode of respiratory viruses like SARS-CoV-2? Mainly, you can get it through contact, which is patient to finger, or from fomite to finger. Fomite is just an inanimate object, or finger to eye, nose, and mouth. And you can have splash and spray, which is ballistic drops that are bigger than 100 micron. So this is an infected person, and if that infected person cough or sneeze, these are the big ballistic drops, which is bigger than the 100 microns, and that can hit in the eye, the nostril, and the mouth, and you can inhale that. This is the exposed contact person here. It's also by inhalation, and inhalable aerosols are less than 100 microns, and it goes into the respiratory tract when they're less than 2.5 to 5 microns, and then it goes into the thoracic area in the bronchioles here when they're about 10 to 15 microns, and respiratory, which means it's inside your lungs in the alveoli, they're less than 5 microns. So to give you a comparison, a hair is 80 microns, and SARS-CoV-2 is 3 microns. So when the indoor air is not still, droplets can travel more than 2 meters, and this is just a slide that shows that the travel distance of droplets can be longer than we think, even more than 6 feet. So when you have low indoor air velocity here, and this is the distance, and these are the aerosols. So mainly what I want to show is that when the aerosol is about even 20 microns, it can go as far as 60 or 70 meters here. So when the droplets are about 5 microns, it can even go as far as 270 meters. So you can see that, so it's beyond 6 feet. So there's still, we know that they're large, but there are also small droplets, as I demonstrate here. So when you have high indoor air velocity, it actually travels a lot more. Low indoor velocity, it travels 60, but even high indoor velocity, it travels even higher. And you're talking about aerosol that's even at 20 microns. So the indoor air velocity plays a big role into the distance of transmission in enclosed indoor space. So with turbulent distance, the travel is less, but settling time is more. So what that means is that when you have turbulent distance, it doesn't travel as far, but it lingers in the air a lot more. And for instance, like something like when you travel on the plane, the air from the plane is from above to down, but just the heat of your body actually when you breathe out, it projects the aerosol up, so up above you, and so it may travel less, but it can linger longer. So this is very interesting. I wanted to kind of point out, and I'll summarize all this study. What it shows is that mask does work. And when you wear masks, even in an enclosed situation, an enclosed area that you're exposed to someone with that are infectious, when you wear a mask, it decreases your viral load. And we'll talk about what viral load is and how much is the viral load. And it actually, even if you are exposed to somebody, you will have mild symptoms. Most of the people have mild symptoms. And if you, it also will, wearing masks will also increase more asymptomatic cases as well, as demonstrated by these events that you hear about here in the cruise ships, and also in these plants here. So just a little about the mask is that wearing a mask is it mainly protect. It doesn't mean that you will not get the aerosol. However, if you're protecting yourself, you're protecting other people actually. So even this is the cloth mask and a surgical mask and an N95 mask here, and so when someone is infected and they are a cough or sneeze or even singing or yelling, you can if you wear a cloth mask, the particle that leak through the mask is about 33 versus a surgical mask is a little less, versus an N95 mask is 1. However, you can protect others if you're an asymptomatic carrier. Because the particle right here, so if you're, I'm sorry, what I meant is that the particle that's produced by coughing. So if you are, if this person is sick, if you wear a mask, you're protecting other people more than in this scenario here where you're protecting yourself, because the particle that is leaked to the environment is, with reference values here, it's 100, it's about 90, 50, and 30, depending on whether it's the cloth, surgical, or N95 mask. So let's talk about testing. What testing is here. So talk about testing. You hear a lot about what is RT-PCR. So RT stands for reverse transcriptase polymerase chain reaction, and it's actually a genetic test. What it does is that it tests the RNA of the virus, and it is a swab test, and it's only done in designated laboratory facility, and it can give you result depending on the facility up to about 2 hours, but it's real in reality it's about 2 days to get the result, because it this machine can take in thousands of swab tests at one time, so it doesn't run one by one, and you get that through the swab to either into the nose or even orally as well. And then the next one is called nucleic acid test. This tests each swab individually, and it is a swab test, and this could be more of a bedside machine. And then the next one is called the antigen test, which is a swab either in the nasopharyngeal or oral, and it's actually pull out the it tests for the protein spike of the virus. It is not a genetic test like the PCR. It is also a swab test, and it could be at the point of care, and the result is in 15 minutes. And then you have the antibody test, which you hear a lot of these terms interchangeable, but antibody test is from the blood. So you hear the word serology, which is the blood test that the facility where you can either do finger sticks or even do a blood draw. and it gives you an immune response that you develop to the virus. And it's usually run in the lab, but you can also have point of care tests as well. Okay, so there's also a SARS-CoV PCR test that it can be done at home. This is through LabCorp. So viral load. So interestingly, viral load and infectiousness infectiousness are highest early in the disease course. So what this means is that this is a testing from the PCR, which is genetic test that I showed you earlier, is that this is days from symptoms onset. So your most infectious really within about 10 days when you have the highest viral load. And what this picture graph shows is that this is inferred infectiousness, and this is days from symptoms onset, when you first have symptoms. So you have the highest viral load really about 2 or 3 days before you even have symptoms. And when you do have symptoms, the days of testing is very, very like within like literally probably 2 to 3 days to even be testing positive. So this is where SARS-CoV-2 is most dangerous, in that people are spreading the infection even prior to them being symptomatic, and that's when the highest viral loads are. The viral load do decrease over time. So what this shows is that this is the RNA of the SARS-CoV-2, the copies and the duration of symptoms. So what they did was that they took swabs of individuals that are has COVID, and they're trying to see the days. Every day they get tested, and it seems that the swab grows positive culture up to about 15 days, and then after that is negative right past 15 days right here. But you also notice there are some individual that can also have live virus that is a positive culture even by 21 days here. So as I mentioned before, that live virus, so I mentioned before that these are days since the infection, not days from symptoms, and this is the virus concentration. So what this slides really show is that most of the window for testing is very small, and because of the virus kinetic. The windows for testing for a positive result is before you even have symptoms, it's about 3 to 5 days after exposure. And so this is a short window here. So when you have a high sensitive test like the PCR test, which tests for the genetic component, you can pick it up right here really early before the person even transmitted. But this is sometimes even before symptoms. So so the person may not know they even have symptoms. So this area here is when the virus starts to grow 3 to 5 days after exposure. The virus grows exponentially over, and then it goes down after 10 days. So the PCR test will pick it up because it's a high sensitive test, and there are other tests that are low sensitive tests, like the antigen will need higher viral concentration to pick it up. So the point here is that it's a very short time to pick this up before somebody become infectious, and that unfortunately most of the time we test along right here, because somebody by this time they start to have symptoms, which is between 7 to 10 days or even 5 days, and then somebody get tested, and it takes about a couple of days for that to come back. So it's a very short window of time, and so the timing and frequency is very critical, because when you get tested here, you may be negative, and then you think, oh, I'm not really infectious, but maybe at that time you already had less viral load. Well, it doesn't mean that you may not be infection, but you may still have the infection. So that's where the antibody tests come in. Okay, so what this says again is that we do have a rapid test, but the sensitivity is very low. And as I mentioned before, that most PCR tests are around right here when you have less viral load. So let me go through this here. All right. The timing and testing of effect PCR. So I had alluded to that, where this is from days of exposure. So the sensitive test, this is serology, which is blood, which it tests for antibodies. And this is PCR, which tests for the genetic component of the virus, which is the most sensitive test. And this is an inverse relationship where patient presenting to the hospital, their test is the highest. The positive test is the highest within about really 10 days after onset. And then the antibodies start kicking in for around 10 days and then remain at around 21 days. So this is the antibody, and this is the PCR test. So the main point here is that sensitivity is secondary to frequency and turnaround time for COVID-19 surveillance. So what that means, simplified term, is that if someone is exposed and they start to get tested right here with the test sample, and this is the viral load, and this person has a high viral load, it takes a couple of days for the test to come back to have a positive test. Unfortunately, when that couple of days is day 8, at that time, that person is infectious, right here. And so if we catch people earlier and do screening, you may prevent about 32% of infectiousness of people that are waiting here, as well as 37% that within the last 12 days, that is around right here. So if you're going to do screening, what this graph say is that you should do screening to pick up for anyone that could be infectious really within every 3 days. So you will see professional athletes that are right now in a bubble, they get tested every 3 days, and this is where it comes from. So what's the best approach? We're going to discuss that. So I talked about virus testing. There's 3: the nasal swab to the PCR, and then serology, which is the blood test, which start to be evident in probably about 2 weeks. And the PCR test we talked about, it could even be the viral load here before the onset of symptoms. So the virology, the PCR test detects if the cases are detected, you can act and isolate and contact trace, and they are transiently positive 1 to 3 weeks, and I talked about why. And it has a high sensitivity for individual infection. So when you have a positive PCR, it says that you are infected, but you can miss many individuals if you test that late. And then the serology, which is the blood test and antibody test, is positive, probably around 2 weeks. And then it can remain positive for months to years. And it has a high sensitivity for population transmission, and is powerful for surveillance program. So I love this slide here. So how do people get sick and where? I want to stress this, and I bold that is an infection equate to an exposure to the virus, which is the viral load, or at time. So the more time you are in an area with someone that is infected, the more chances of you getting an infection. So cough releases about 3,000 droplets, and the droplets can travel 50 miles an hour. Most droplets are large and fall to the ground. Small droplets, as I've talked about before, can travel across the room in a few seconds and lingers, could even be for hours. A sneeze releases 30,000 droplets, the droplet traveling up to 200 miles an hour. Most droplets are small and can travel great distances, like I mentioned before. So if a person's infected, the droplet in a single cough or sneeze can contain as many as 200 million virus particles, which can be dispersed into the environment around and can stay up for 3 hours. A breath releases 50 to 5,000 droplets. Most of the droplets are in low velocity and fall to the ground quickly. And the fewer droplets, there are fewer droplets with nose bleeding. Thus, it contains less levels of the virus. Just speaking, like I am right now, increases the release of respiratory droplet tenfold, about 200 virus particle per minute. So do we have data that we can extrapolate from the flu? And individuals infected with influenza can release up to 33 infectious viral particles per minute. So let's do some math. Let's say you're in a room with somebody that is infected, and that person, as I did a single cough, that person's releasing 200 million virus particle. And for it to be infectious, the dose of SARS-CoV-2 is 1 to 3 million virus particle. So if that person just one cough, and you're in the room, it only takes a few minutes for you to get 1 to 3 million virus particles to become infected. And so the successful infection means the exposure to the virus, if you have somebody infected, that's a lot of exposure to the number of the virus times the time. So we're going to talk about some certain scenarios. So infectivity, 44% of infection, which is community acquired, occur from people without symptoms or the asymptomatic one. And we talked about the virus can be shed 5 days before symptoms can begin. And virus shedding does not decrease with age. It doesn't mean that if the older you are, you shed less virus. And the viral load can build up to a point where you are symptomatic. And you release the most in the environment before you become symptomatic. And this is very interesting. 20% of infected people are responsible for 99% of the viral load that's released in the environment. That's almost like the 80-20 rule. So let's talk about some super spreading event about what that prove what I just said about viral load times time. Meat packing plants, which are densely packed, and workers in a co-environment, because it's loud, they yell and talk to each other. And then also at places like wedding, funerals, and birthday. Let's take an example of an individual in Chicago. He went out to eat dinner, and he shared takeout with 2 family members, and the dinner lasted about 3 hours. And 2 out of 2 of the infected family members were infected. And then one of the infected person attended a funeral, and from that funeral, another person got infected. And then the same man attended a birthday party, and 7 out of 9 people got infected. And one of the infected person at the birthday party went to church, and the members in church were sick, and a total directly infected was 16 people from the original person that did the takeout, and 3 of them died. So as you can see, the infection spread is quite prominent. And we also see this in business networking event as well, and in the Biogen in Massachusetts. That's why all my conferences are canceled, and they're all virtual at this time. Let's take another scenario. This is a very interesting scenario where this is at a restaurant, and the air conditioner is flowing from right to left, and this is the exhaust fan. And A1 is the infected individual, went out to dinner with 9 friends sitting at table A. The dinner lasted about 1 to 1.5 hours. The airflow is going from right to left. So 50% of the people that at the person table is infected, and 75% of the people in the downward table right here are infected. So as designated by the red circle here. So this person's infected January 20. This person's infected here, and these are the people that got infected that show symptoms on January 29th. And these are the people that start to show symptoms on February 1st and February 5th. Interestingly, the 2 out of 7 people upstream from the air conditioner also got infected as well. And these people were not masked. So they're in an indoor environment and not masked. As another scenario is in the workplace. So this is at the call center where an infected employee works on the 11th floor here, and there were 216 employees, and in a week, 94 out of 216, or 43%, became infected. So as shown by these blue color here. And interestingly, another 3 people on other floors were infected, were not able, but they were not able to trace it to the primary cluster on the 11th floor. So this is other people from another floor. So what this shows is that in the workplace, you could have about 43% spread. So what's the commonality of the outbreak? It's indoors, no social distancing, talking, singing, and yelling. And 90% of all transmission is in the home, the workplace, the public transport, and the gathering and restaurant. So what's the 5 roles of testing in COVID era, especially in the workplace, is identifying, you want to prevent the spread. And that's by identifying infected and contagious member of the workforce as early as possible, so you can isolate and quarantine them and perform contact tracing. And then you also want to mitigate the risk of complication and hospitalization for infected people as well, by having them diagnosed and being treated appropriately. And you want to safely return to work, ensuring that infected members of the workforce are no longer contagious prior to their return, and also the workforce deployment and identifying those members in the workforce that are susceptible and may have developed antibodies and presumed immunity. And then also the workforce and public confidence, establishing a confidence in the company's approach to COVID risk mitigation. So employer and departmental risk assessment. So you want to ask questions: does the organization provide healthcare services directly to patients? Does the organization directly interact with high risk members of the population? Or certain members of the organization at particular risk as well due to travel or public interaction? And do members of the workforce in close proximity to each other or in setting of which COVID-19 could easily spread? And have there already been known or suspected COVID cases? And is the organization mandated or advised to demonstrate COVID-19 risk mitigation strategy? So why is testing and health surveillance for COVID-19 is unusually important? I mentioned the need for testing and the critical role of testing at this point. So you want to detect infections and contagiousness in those that are asymptomatic and symptom-free. The time for exposure to SARS-CoV-2 to develop symptoms is really 3 to 21 days. 90% of infected people who develop symptoms do so within 14 days. However, as many as 10% may take longer to develop symptoms. Many people never develop symptoms but are still contagious. Those are the asymptomatic. So given these facts, as employer, you must apply well-designed testing strategies that are calibrated to the need to control COVID risk within your population. So timing and testing for COVID. COVID-19 is detected, as I mentioned before, a viral RNA. So that's through the PCR test. And the samples can be taken from the nose, throat, saliva, or sputum. And the tests evaluate for the viral nucleic acid, so it's genetic test. Viral RNA shedding can begin around 3 to 21 days. And okay, so we talked about the 14 days symptom begin, and shedding does not equate infectiousness. You can shed dead virus that the body's already killed. So one thing to know is false negative. So there do exist false negative depending on what machine you do, and also who does it and where. So the RT-PCR test, which is the highest sensitivity test, is gathered and is the gold standard, gathered in the nose and the throat. The PCR test is actually, if it's done correctly, has about 97% sensitivity. So sensitivity shows that whoever they're tested for is positive for it, and there's only 3% chance. If you have a 97% chance of sensitivity, there's 3% chance of false negative. And so, but depending on what test you use and who does it, the false positive rate can be as high as 15 to 30%. And this actually happened to me when I first had symptoms. I went to get tested 2 days after my symptoms, and I did a rapid antigen test, and it was negative. So it was negative. So, but I continued to have symptoms 3 days later, and went to get the PCR, PCR test, and I was positive. So I was tested too early, but I also did the rapid test, which is not the highest sensitivity test, which has about 30% false negative. And so the majority of the result collection procedure could be done inappropriately because you can collect in the wrong place or not enough. And you can collect it outside the diagnostic window, like I said, and also the handling, the transport, and the storage of the swab, as well as the presence of interfering substances or contamination play a role as well. So antibodies again come from the blood, which is serology, and antibodies develop because you've already been infected and you have the exposure, and your body is fighting the virus. So antibody production occurs between 5 to 14 days. And the timing antibody development is either IgM, which is the early antibodies, and then you have IgG. And it could vary across individuals. So some individual can mount up a good immune response. Some individual can't. And some individual may have a delayed response. And median antibody production is at 15 days. And IgM antibodies tend to be the body's more general and immediate response, which I'll show you in a graph later. And IgG antibodies are the long-term immunity. So this is an interesting graph. So follow with me on here. There's a lot of information on this graph, and I'll walk you through it so you can have an understanding what all the testing mean. And this is from an aggregate view based on a number of published studies that come out before testing and also for antibodies. So down here is the time after onset of symptoms. So this is symptoms, not exposure, but exposure up to 3 weeks prior to symptoms. So this illustrates the likelihood that an individual may have a positive test after symptoms onset. So viral culture is the purple line right here, and we talked about that earlier. So viral culture, the highest between day 3 and day 5, and then it starts to decline about day 10. And this here is percentage of positive patient. So this is the viral culture, and then here is the viral RNA, which is tested by the PCR test, all right, from the nasal swab. So you get a positive test between day 3 to day 10 here, and then it starts to go down. And then around day 5, you start developing IgM antibodies, which are the dark blue line here. And that mounts up to around the the second week, and then stage about the fifth week and start to decline. The IgG antibody, which is the long term antibody, start to kick in and about day 10 and peak at around 21 days. So this is the one that confer long-term immunity. This is the short-term immunity. And if this is positive, what that tells you is that somebody is infected. But if you have a positive IgG, you don't really know when that person's infected. You can test this 3 months out, and you don't really know whether this person's infected a month ago or 6 months ago. The IgM antibody shows you that an individual is infected probably about 5 weeks ago. If you have this window right here. All right. So immunity is serology with blood. And I keep stressing that because sometimes it can be a little confusing. So while it appears 100% of individuals who are infected, who had a positive PCR test, go on to develop some type of antibody response, there's a variability of individual whether they can mount this or not as well. And antibody levels also appear to correlate with severity of disease. So the more severe the disease is or symptoms, results in a higher viral load and also higher antibodies levels. Like for myself, for instance, I had a high viral load and I had more severe symptoms, and I probably have a more robust antibody response, and particularly probably my IgG response. So I will be a great plasma donor to help other COVID patients in the future. An individual with underlying immune competence will also affect whether they are capable of mounting an efficient immune response that result in a positive antibody titer. So even more confusing if you're immunosuppressed and if somebody that's on steroid or somebody that's elderly, somebody that takes immunosuppressive medication, you may not be able to mount this and you may test negative. Doesn't necessarily mean that you have not had COVID either. Many people never develop symptoms, but may still develop antibody response. And that's why testing antibody response asymptomatic people could be helpful. The importance of test selection. So antibody or blood test, again, is not made the same as we had, that's I had mentioned also about the PCR test. So the purpose of antibody testing is to determine the presence of specific antibodies and to find out if someone's been infected, not currently infected, been infected. And that, however, the viral antigen that is used to test for SARS-CoV-2 could also be very similar to the coronavirus, which also can cause the common cold as well. So sometimes can cause a false positive test. Unfortunately, FDA emergency use authorization does not provide a high level of rigor required under ordinary circumstances. So there are many lab kits out there which may not be as valid. So, bear with me here. These are important things to pay attention here about individual symptom-based scenario. So if a person has a known exposure but asymptomatic, you want them to quarantine for 2 weeks and then test for antibodies and viral RNA 2 weeks post-exposure because they're asymptomatic, so you have to use post-exposure. And I have a detailed slide to show that later on. And I'm also gonna put in the chat box about isolation and quarantine duration that you can use. So an individual that has mild or non-classic symptoms, you perform a viral RNA test to confirm the infection. If the viral RNA test is negative, then perform antibody test 7 days after symptoms resolve. So 7 days after symptoms resolve. If negative, consider another confirmatory antibody test in 1 to 2 weeks. If viral RNA is positive, or the PCR test, perform the antibody test 2 weeks after symptoms resolve. And it is prudent to confirm a second negative PCR test or RNA test prior to returning to work. Individual symptom-based scenario. So when an individual has classic symptoms, you want to perform the PCR test. to confirm the infection. However, if the PCR test is negative, perform the antibody test 3 to 7 days after the symptoms resolve. If negative, consider another antibody test. If the PCR test is positive, perform the antibody test 2 weeks after the symptoms resolve. If negative, do another test in 2 weeks. You want to make sure that an individual returning to work have a negative PCR test. So I hope you can see all this here. So individual testing scenario. So this table provides a guide for interpreting and acting upon the variety of testing scenario. I presented a couple of cases, but so if a person is symptomatic or have symptoms and they had the PCR test and that tested negative, and then they also have antibodies and that tested negative, they are susceptible at this point. So social action would be social isolation to prevent contacting the virus and defining the risk. If a person is not symptomatic but tests positive for PCR, test negative for antibody, that person is currently infected and need to be quarantined and need to be retested RNA and antibody test in 2 weeks. Person is not symptomatic, a negative PCR test, but have a positive antibody test, and that shows that past exposure immunity is likely and can return to work if the individual is symptoms free, and 7 days without 7 days of resolution of symptoms, and also have a negative PCR test. The individual is not symptomatic, positive PCR test, positive antibody, which showed infected with developing immunity. You want to quarantine and retest for RNA and antibody in 7 days before returning to work. And then if someone is symptomatic, testing negative on PCR, test negative on antibodies, you assume infected and quarantine for 14 days and consider second RNA test to confirm. And if somebody is symptomatic, positive PCR, that person is infected and need to quarantine and retest an antibody test in 2 weeks. Symptomatic, negative PCR test, but positive antibody is infected with developing immunity, quarantine and consider second RNA test. And of course, if all of this is positive, infected with developing immunity, you want to quarantine again. So screening precaution for employers, ensure that unless otherwise requested, COVID-19 screening test. So if you are paying for your employee to get tested, just make sure that they're not tested for the flu or other viruses, because you can be billed for that and it's pretty costly as well. Sometimes when you go to ER and they suspect you have COVID, they do run these tests as well. Understand the time required for the lab to produce results. And every day that it passes, the value of the screening goes down. That's why I talked to you about the time of infectivity and the PCR test. And there's now a rapid antigen test, which antigen test is a nasal swab and it tests for the protein of the coronavirus. And you can do it individually, but it's not a genetic test. And it was just released, and it's a point of care test, and you can get the result in 20 minutes, and it has a high 97% sensitivity and specificity. So recommendation for COVID-19 testing is partner with a local medical practice or group that can do the testing for you, ensure a good turnaround time and follow-up. And that ensure you're not overpaying for other unnecessary tests, and can implement facility on-site and home-based screening, can offer virtual telemedicine screening for a high-risk individual or infected individual as well, and can also do some risk tolerance for you. So screening scenario and back to work. Antibody testing for the entire asymptomatic workforce. Symptomatic employee remain quarantined. We discussed about that before. Employees with negative antibody tests may return to work if dictated by organization risk profile, depending on their medical status, and should receive a confirmatory PCR test prior to returning to work. Positive antibody results are followed by an RNA test to confirm no infectivity prior to returning to work. Anyone with antibody positive employees should be logged into the registry, and there may be excused from screening, but we don't really know how long this antibody will last. Studies have shown up to 3 months, but we really don't know at this point. Other screening scenario you may consider is early identification of infection, and this may be done with home testing that I had talked about. With individual or group testing, you can do staff testing as well for the PCR test on a proactive basis. I know some companies test their employees every week, every 3 days, and some even every day. You want to assess for previous exposure and immunity assessment with the staff or department or shift level. And this can tell you the organization previous rate of exposure and which employees have immunity. So sick leave, I wanted to mention that this is indicated on CDC website. There's the Family First Coronavirus Response Act, which requires certain employers to provide the employee with paid sick leave or expanded family and medical leave due to COVID. And employers with fewer than 500 employees are eligible for 100% tax credit for the Family First Coronavirus Response Act paid leave provided through December 31st of 2020 up to a certain limit. So check it out on the CDC website. Just a quick thing on the framework for transmission mitigation is that occupational health is different than public health. So on the workforce, you want to have very low risk tolerance, and the goal is to reduce risk to an irreducible minimum. And the focus on efficacy. So how do you really provide ideal protection, like I mentioned before, and it's an individual perspective versus a public health perspective. It's totally different. The risk tolerance is somewhat greater because you can't control every factor. You want to reduce the infection. The R0 is you want that to be R0 mean how many people an infected person infect. You wanted that to be less than one person. So R0 or R0 for SARS-CoV-2 is 2 to 3 people. So one infected person can infect 2 to 3 people on an average. And on the public health perspective, focus on effectiveness, and it's really a utilitarian perspective. So risk assessment. Again, it's a recap of what I said. How many people are in the workplace? What is the airflow? What direction is the airflow? Filters? How long are you in the environment? Remember what I said earlier, is exposure or positivity times viral load. So how much viral exposure times the viral load. So when you're walking past someone that is sick, the risk is very low. You have to be in their airstream for more than 5 minutes for a chance of infection. So you want the employee to take a daily temperature and symptom check for COVID-19. Employers are doing staggered shift at 50% capacity in the office, social distancing. Also go to the CDC website, tons and tons of information on workplace recommendation. All right, this is very important, and I kind of want to point this out, and that we can mitigate and really reduce the reproductive number of infection of COVID-19. And that equation is number of contact per day. So how do we reduce that? We reduce that by social distancing, self-quarantining. You work from home, cancel social gathering. So this equation means the effective number or the spread of the virus is due to the number of contact times the probability of infection per contact times infectious period times population susceptibility. So we can reduce the number of contact by doing social distancing. We can reduce the probability of infections per contact by wearing protective personal equipment, personal hygiene, and masks, hand washing, and then we can reduce the infection period by contact tracing, case isolation, and timely treatment. And population susceptibility is vaccination, which hopefully will occur by 2021. I want to put in that you can boost your immunity by doing very simple things as eating healthy, exercise, no smoking, drinking water, eating a lot of good vegetables, dark chocolate, take a probiotic, exercise, meditation, IV vitamin C, and also there's a study that's shown that you can boost your immunity protein, which is IgA, by watching acts of kindness video or reading, or write about the time that you perform acts of kindness or engage in acts of kindness. Population prevention initiative at this point is that you can actually do preventative measurement. For higher risk members or even executives, there's home testing for genetic and lifestyle related immune risk factors. You can do a home test to look at vitamin D, your glucose, your hemoglobin A1C, and this is high sensitive CRP, which measure inflammatory inflammation level in your body. You can also do a saliva test to test for your nutritional deficiency and also genetic risk factors like epigenetic. I won't have time to go over this at this point, but this is very interesting thing that you can actually do this to determine your risk factors. And also population-wide vitamin D optimization. There's studies, multiple studies come out that correlate low vitamin D correlate with mortality, lowers immunity and cardiac morbidity. So if your levels are less than 60 or even 50, you should get supplementation vitamin D either through an injection or through oral. So when will this all end? Well, interesting. I've been asked this question a lot. So we need to do testing to identify who's infected, not infected, who's immune. And I talked about the blood test. Effective social distancing. We must have a high degree of population understanding, the solidarity and discipline that is required for personal hygiene, mask, coughing etiquette, self-monitoring and social distancing measures. We must have enough protective personal equipment for health personnel, ICU beds and ventilator, which we currently have right now, and the staff. Treatment for antiviral, vaccine, and cytokine. We right now do not have definitive treatment for COVID-19. And everything is still in clinical trial. New cases and death declining. We need to flatten down the curve. We need, I want to stress, it takes about 2 to 3 months to really control the spread of the of COVID. If 80% of the population wear masks, do hygiene control and social distancing, and we may have pockets of disease outbreak, and that will require longer social distancing and quarantine other areas. The main thing is we don't get rid of the virus. We really don't. We just control the outbreak like we do with the flu, and SARS-CoV-2 will be here like the flu. And there will be a vaccine, and hopefully we'll develop herd immunity. And herd immunity is when 60 to 70% of the population has been infected. So this is my contact. If anyone has any questions, and I believe we put in a PDF for isolation quarantining guideline under the chat box. If that's not under there yet, or you can always email me for that. Yeah, Tori did that. So you can go to the chat box. Yeah, to go to the chat box and download that. And we can take questions now. So do we unmute, or you want them to type it in the chat box?
Yeah, I mean, if anybody has a question, feel free to unmute and fire away.
Hey, and Alex here. Thanks for all the details and the deeper understanding of this whole thing. I I don't per se have questions. I think you answered everything, but just want to say thanks for the presentation.
Well, thank you. Thank you. I know there's a lot of information we recorded. You can watch it again. If you have any questions, always contact